We present a novel simulation model for a rescue cervical cerclage, also called an exam-indicated cerclage. This simulation will improve training for resident physicians and therefore enhance patient outcomes. This procedure can have adverse risks such as preterm pre-labor rupture of membranes and preterm labor, which makes proper training critical. Due to the risks associated with the procedure, some physicians do not feel comfortable performing it. This model has realistic anatomy and replicates the cervix being approximately 3 to 4 centimeters dilated, 70 to 80% effaced, and with bulging membranes. Due to the advanced dilation and bulging amniotic sac, this model can be challenging. By providing simulated training, the goal is to increase a physician's level of comfort when performing this procedure. A rescue cerclage is indicated when a patient has painless advanced cervical dilation in the second trimester prior to 24 weeks of gestation. The procedure involves placing a stitch in a purse string manner around the cervix to reinforce and close the cervix. In a rescue cerclage, up to 50 to 90% of patients have bulging membranes, which makes cerclage placement challenging and critically important that providers are trained with the proper technique to avoid complications such as preterm pre-labor rupture of membranes. It has been reported that the rate of rupture with rescue cerclage placement is as high as 30%. Other complications include intraamniotic infection and cervical and vaginal wall lacerations. This means that proper technique is of the utmost importance, highlighting the need for simulation in practice. The Cerclage model is designed using easily accessible materials, including common household items and supplies typically found in the hospital, making it both practical and cost effective for simulation. Materials include a 3-inch PVC all hub sanitary tee, a 1 quart sharps container, silicone tape, a balloon, pipe cleaners, and an expired Foley catheter, placing the total per model at $33.10. This is the fully assembled model using the various items listed. Here, the model features external genitalia made from silicone, which can either remain attached or be removed for the simulation. For video purposes, the external genitalia were removed to improve visualization. This image shows the setup for the simulation and shows a dilated and effaced cervix with visible membranes. This image shows the cervix after cerclage placement, demonstrating that the cervix is now closed. These are the instruments used for cerclage placement. This includes Mayo scissors, ring forceps, Alice clamps, hemostats, a needle driver, a weighted speculum, and a right angled retractor. A Deaver retractor may also be used. There are various types of sutures that may be used, including Prolene, Ethibond, and Merceline. These are permanent sutures. The suture choice is typically dependent on provider preference. Not pictured here is also the use of a Foley catheter. The patient is taken to the operating room and spinal anesthesia is administered. The patient is then placed into the dorsal lithotomy position and prepped and draped in the normal fashion. The bladder is drained using a red rubber catheter. A weighted speculum and a right angle retractor are placed for visualization. The anterior and posterior lip of the cervix are grasped using ring forceps. A Foley catheter is then inflated using 30 milliliters of fluid to help displace the amniotic sac cephalad. If the amniotic sac is still bulging after placement of the Foley catheter, a ring forcep may be used to displace the amniotic sac even further. The end of the suture is tagged with a hemostat. The cervix is stabilized using ring forceps, which also help by providing traction. The needle is introduced at the level of the cervico-vaginal junction, which can be identified by the presence of vaginal rugae. The needle is advanced as close to the internal os as possible while remaining within the cervical stroma, avoiding entry into the cervical canal. The suture is first placed at the 12 o'clock position and passed circumferentially in a purse string fashion around the cervix. Special care is taken to avoid placement at the 3 and 9 o'clock position, which is where the cervical vessels are located. After completing the circumferential pass, the suture is brought back to the 12 o'clock position where the knot is tied. If a sponge stick was used, it would be removed at this time. The Foley catheter is deflated as the suture is cinched. The Foley catheter is then removed. An air knot may be intentionally placed to facilitate identification of the suture at the time of cerclage removal. The tail of the suture is then cut. According to the American College of Obstetricians and Gynecologists, there are no definitive recommendations for or against the routine use of tocolytics or antibiotics at the time of cerclage placement. Management should be tailored to each individual patient. Patients are typically discharged the same day once the effects of the spinal anesthesia have worn off, and they are able to ambulate, void spontaneously, and tolerate oral intake. They are usually seen back in the clinic in 1 week for follow up. Routine cervical length measurement after cerclage placement is generally not indicated. A cerclage is typically removed between 36 and 37 weeks of gestation, usually in the outpatient setting. However, a cerclage may be removed sooner if there is cervical change, painful contractions, or vaginal bleeding.